Hello, my name is Tracy Goodman. I'm a Senior Patient Services Team Leader for STARS. Today we are joined by Dr. Robert Briggs. He's a consultant geriatrician at the St James's Hospital in Dublin in Ireland. Thank you.
Hi everybody, and thanks for the opportunity to present on our Syncope service. So I'm going to present on the impact of a specialist service we developed in the emergency department for patients presenting with syncope, falls, or dizziness. So before we set up our service, which is called the Emergency Department Falls and Syncope Service, in our emergency department here in St James's, about 10% of presentations were due to a fall or a faint or a combination of both. About 1 in 3 of those patients who presented were subsequently admitted to hospital. So obviously a very high admission rate. And this, I suppose, then comprises a significant proportion of acute hospital activity. So even after admission, though, it's unclear whether the admission was entirely beneficial for these patients. So when we looked at it, we found that almost half had no formal diagnosis for their fall or their faint by the time they went home from hospital. About 1 in 10 had an inappropriate EEG, which didn't really reflect what was required based on the presentation. And nearly half had neuroimaging that wasn't required either. So these individuals who were admitted maybe had some inappropriate testing, but also didn't necessarily have appropriate testing that they required, and didn't ultimately get a diagnosis for why they presented in the first place. This graph just shows before we started the service what the chances of admission to hospital were when you presented with a fall or a faint. And you can see, particularly in the older age group of patients over the age of 70, that almost 60% were admitted when they presented to hospital. But like I said, they may not have derived an awful lot of benefit from this admission in terms of a diagnostic answer for their presentation. The typical course, particularly for an older person who presents with a fall or a faint, can be complicated as well. They're usually, when they present to the emergency department, deemed to be category 3, which is urgent but not immediate care, and they have a long wait or patient experience time in the emergency department before they're seen. They tend to initially be seen by the emergency department doctor, who then refers on to the general medical team, maybe as a collapse query cause. They may await a specific bed in the emergency department, a telemetry bed. That means, you know, their heart rhythm can be monitored, so they spend even longer in the emergency department than an average patient. They have some tests that maybe don't necessarily yield an answer as to why they fell or fainted in the first place. They ultimately may stay in hospital for 5 to 10 days, and then almost half, as I said, would go home without a diagnosis. And we know this because we looked at it and we found that the most common diagnosis were fall or syncope, which is a symptom really rather than the actual cause for why they presented. So we wanted to improve this. We want to do something about it and make it better. So we established an emergency department falls and syncope service, using our falls and syncope unit here in St James's Hospital. And this really had, I suppose, 3 pillars. The first was that we would have an emergency department front door service where we would see patients who presented with a fall or a faint directly in the emergency department, and we avoided the need for them to be seen by any other doctors. We provided a same-day consult service where patients admitted with falls or faints to the hospital out of hours. And we provided rapid access clinics to our falls and syncope unit for patients who presented to the emergency department out of hours also. And we saw patients with falls, faints, and pre-faints or pre-syncope. Our ED front door service, as I said, involves us seeing patients directly in the emergency department. We see around 4 to 6 patients per day on average here in St James's. And this has led to a significant reduction in the admission rate from the emergency department. As well as that, it has led to a significant reduction in the amount of time patients have to wait for care in the emergency department. So we've reduced our patient experience time. And our mantra, I suppose, is that everybody gets a diagnosis, even if it's a working diagnosis, before they come home. So 100% of patients have a diagnosis for their fall or faint before they leave the emergency department, even, as I said, if it's just a working diagnosis that needs to be refined over time. We run, as I said, a same-day consult service for patients who are admitted outside the hours that our service operates, which is, I suppose, 9 to 5, Monday to Friday. We see 8 to 10 patients per week, which has increased significantly since we started the service. We see the patients very quickly, and that has led to a significant reduction in the amount of time patients spend in hospital after a syncopal episode. But it also has meant again that they don't leave the hospital without a diagnosis for why they fainted or fell in the first place. A rapid access clinic is a dedicated weekly clinic, but we can see any patients within 24 hours. So any patient who presents with a faint to the hospital that needs to be seen quickly can be seen within 24 hours in our specialist clinic. And over 1/3 of the clinic referrals overall in our department now are from the emergency department. So since we started, this shows the impact of the service on admission rates, and overall across age groups, our admission rate for patients with falls or faints have reduced by 20% since the service was introduced. And that's for all times of the day, so no matter when a patient presents. But as I said, more important than the reduction in admission rates, I think, is that patients don't leave without a diagnosis. As well as that, when patients are admitted, their length of stay is also reduced significantly. So since we introduced this service, patients stay on average 3 days fewer in hospital than they did beforehand, which has knock-on effects, not just for the hospital in terms of increasing bed capacity, but also for patients, particularly older patients, who can suffer harm when they're admitted to hospital in terms of hospital-related infection or delirium or impact on mobility, particularly in older people. The amount of bed days used to care for people with falls or faints has reduced significantly as well. That's in line with us, sending people home from the emergency department who previously may have been admitted, but also reducing the length of stay for patients who present to hospital. So essentially a 50% reduction in bed day use. And that means that patients with falls or faints, spend half the amount of time in hospital that they used to. As well as that, and really importantly, is that we wanted to look at readmission. So we looked at in 3 months' time, when we saw patients in 3 months' time, what happened to them. So these are patients we reviewed in the emergency department, and we found that patients who were seen by our service had a lower likelihood of readmission to hospital at 3 months. So not only were they less likely to be admitted on the day, but it also reduced the likelihood of admission subsequently. And we think that's because we establish a working diagnosis. We start treatment if appropriate, and we link the patients closely in with our specialist clinic. So it's not just on the day where we reduce the need for admission, it's subsequently down the line as well. So in terms of our service, I suppose the key achievements is that we've most importantly enhanced the care of patients who present to the emergency department with syncope. There's been a 20% reduction in admissions. Patients stay on average 3 days fewer. They're less likely to represent, and then less likely to need to use hospital beds during that time. So that's our service. So thanks a million for listening, and I'm happy to take any questions that may arise.
Thank you, Dr. Briggs. That was very informative. Thank you for sharing that with us. I do have a couple of questions, if that's okay to ask.
Mm-hmm.
So first of all, it is well known that syncope services established over the years by Professor Rose Ann Kenny have always led to reduced hospital stays and reduced readmissions. This is another excellent example that you and Professor Kenny's team have shared, so thank you. So first question is, with the current state of healthcare across nearly all the countries, how can others adopt this example of pioneering work?
Yeah, no, absolutely. I mean, it's in the UK and Ireland and the UK, there's massive pressure on bed capacity in acute hospitals. And we really need to look at ways where ambulatory conditions can be managed outside of an acute hospital in a more appropriate environment. And this is one way, and it's something that could be adopted, in lots of hospitals. I suppose how we developed it is we're lucky because we have a dedicated falls unit here, and we had dedicated staff who could run this service. So it was important we ran it as a pilot first and demonstrated a benefit of the service, because the service essentially pays for itself when you look at the reduction in bed day use related to the individuals that we see. It could certainly be rolled out. Most of the patients we see don't require high level specialist falls and syncope testing. Most of the patients require a clinical, specialist clinical assessment, an ECG and some routine bloods. Over 70% of the people that we see in the emergency department are managed with that. So you don't absolutely need a specialist falls and syncope unit behind you. So it could certainly be rolled out in other sites. And I suppose the key thing is to get hospital management on board in terms of demonstrating a need and demonstrating an impact of a pilot study.
Thank you. We are aware that services are closing or have extremely long waiting lists. Syncope seems to be slipping off the radar once more, and certainly the cardiovascular training modules. It appears that syncope hardly ever gets a mention. What more can be done about it?
Yeah, and certainly in our units here, we're really struggling at the moment. Our wait times for patients, we used to have really short wait times, and that's just extended. I think, we need to look at increasing awareness of the problem that it is. We at the moment are planning a national audit of falls and syncope in Ireland to demonstrate, I suppose, the lack of specialist care available for this cohort of people, people presented with falls and faints. And our aim is to use that to drive changes or enhancements in clinical care forward. So any way that it can be shown, the lack of access these patients have to specialist care is really important, because I think, we have one unit really in Ireland, but it's not sufficient given the kind of change in demographics we're going to see over the next kind of couple of decades, and we're really going to need more. So to demonstrate a need, again, similarly to demonstrate that need, and the route we're taking at the moment is to try and demonstrate that on a national level with an audit.
Thank you. Is this a model that you think could be easily replicated? If so, how can it be?
Yes, I think so. As I said, the vast majority of patients we see don't require high level falls and syncope unit testing. Most of them we see it's a specialist clinical assessment. So people need to be trained and they need to be comfortable with this cohort and making a diagnosis. But beyond that, it could certainly be replicated. I think ideally you'd have like a hub and spoke model where you have maybe a falls and syncope unit that's fully staffed and set up and stocked, and then that could be the hub for spokes of different, potentially some smaller hospitals or some medium-sized hospitals who could run a service like this and feed into that unit. So while you do need that specialist backup for certain cases, it's certainly easy. The majority of patients can be sorted, in the emergency department with somebody who's trained clinically, with a team who's trained clinically in terms of the specialist nurses and the specialist medical team.
Thank you very much, Dr. Briggs.
That's great. Thank you.
Thank you.